Recording in progress.
It's not raining, you see.
Good morning, David.
Good morning, Gopal. Sorry, good morning, Gopal. How are you?
Good morning, Amma.
I'm doing fine.
Pardon?
I'm doing fine. Can you hear me?
Thank you, thank you. All right. Well, I think the patients with totally went home quite happy.
On Saturday, and I think she's,
Yeah.
they told me she's due back next week for removal of stitches. That's good. Thank you,
Okay.
David.
Sir, can we start the meeting, sir? Santosh sir has said that he's unable to join and we can start.
Yeah, okay, please.
You may join. Thank you.
Sir, is my voice audible?
Yeah, carry on. Yeah.
Good morning, everyone. I'll be presenting the topic on anatomy of the medial aspect of the knee. This is the structure of presentation that I'll be conducting it in. I'll start off with a brief introduction and I'll talk about the components, 8 of the components I'll be discussing about, and I'll summarize it. And I have approximately 35 slides and I'll be taking 50 minutes of your time. These are the 2 research articles that I've been taking bulk of my research from, in addition to other articles. Brief introduction. Why is the medial structure anatomy important? That is because of the typical side of impact that forces the knee into a valgus, the force coming from the outer aspect, the lateral aspect, and directed medially. Second reason is the structural integrity of the bones present over the medial aspect of the femur and the tibia or the knee joint, which makes it denser, more likely for the ligament to be injured rather than the bone, or the soft tissues to be injured rather than the bone, out of which the most commonly injured soft tissue is the MCL. Before we go into the anatomy of the soft tissues, we have to understand the osseous landmarks based on which we'll be conducting the anatomic landmarks. So the 3 points which we have to know about is the medial epicondyle, the adductor tubercle, and the gastroc tubercle. The distal most and the anterior most osseous tubercle is the medial epicondyle. posterior and proximal to which is the adductor tubercle. Adductor tubercle is also the terminal point of the supracondylar or the posteromedial ridge that runs through the length of the femur. Posterior and distal to this tubercle, we have the gastroc tubercle. Important to understand, though these tubercles have the name of the muscles, they are not the attachment points, but serve as the tubercles that is closest to these muscles attachment points. Before we start off with the individual structures, it is important that we orient ourselves regarding the various soft tissue components. This is the axial view. We can see the medial meniscus on the innermost layer and the MCL ligaments, which are two, the deep and superficial. Then we have the posterior oblique ligament, which is a triangular ligamentous structure that you can see over here, and the semimembranosus and the pes anserinus, which are the structures that come from proximal and attaches towards the proximal tibia distally. Starting off with the individual soft tissue components, we'll have the superficial MCL first. This is the largest in the medial aspect of the knee, and it has one femoral attachment and two tibial attachments. The femoral attachment is exactly 3.2 mm proximal and 4.8 mm posterior to the medial epicondyle as seen here, and it runs longitudinally and has two different tibial attachments, the proximal tibial attachment and the deep tibial attachment. So proximal tibial attachment, it is attached to soft tissues and it blends with the anterior arm of the semimembranosus tendon expansion, as you can see here. The distal attachment proceeds distally along the proximal tibia and attaches anterior to the posteromedial ridge of the tibia in close relation to the pes anserinus that you can see reflected here. There is a bursa between the pes and the superficial MCL ligament. Moving on to the deep MCL, this is a thickening of the medial joint capsule, which is found deeper to the superficial MCL layer, and it is roughly parallel to the anterior of the superficial MCL fibers. It has two major components, the meniscofemoral and the meniscotibial. Meniscofemoral being the longer and meniscotibial being the shorter but thicker, and it attaches just distal to the articular cartilage of the medial tibial condyle. Moving on to the posterior oblique ligament, it has three different components, the superficial, central, and capsular, and it attaches distally towards the semimembranosus tendon. These are the three different components that I'll be talking in detail in subsequent slides. The long superficial aspect, the central arm, and the capsular arm. Starting off with the femoral attachment of the posterior oblique ligament, it is found 7 mm distal and 6.4 mm posterior to the adductor tubercle. 7 mm distal and 6.4 mm posterior to the adductor tubercle, and 1.4 mm distal and 3 mm anterior to the gastroc tubercle, which is found here. It is a very thin facial expansion that proximally blends with the central arm towards the femoral attachment, and distally you would find it parallel to the posterior border of the superficial MCL ligament. So this is the superficial arm. The central arm also, in association with the superficial arm, attaches to the common insertion point of the femur, but it is found deeper that it attaches to the semimembranosus tendon, and it is a reinforcement of both the meniscofemoral and the meniscotibial portion of the posteromedial capsule that augments its structural integrity. So both these ligaments are in close association with the superficial MCL. So it is important to differentiate between the two. That is done basically through the different orientations in which the fibers run. The superficial MCL, we find that the fibers run more vertically and along the longitudinal axis of the femur and tibia. However, the posterior oblique ligament, as its name suggests, runs obliquely towards the posterior aspect from the medial insertion point. So more posterior orientation, fan-shaped structure coming in close proximity with the semimembranosus is the posterior oblique ligament, and the vertical ones will be the superficial MCL. The distal attachment of the central arm has three components: the meniscotibial portion of the posteromedial capsule, the osseous structure, that is the posteromedial tibia, and the posteromedial aspect of the meniscus. So 3, that is the capsule, the osseous tibia, and the meniscus. So capsular arm is the third component of the posterior oblique ligament. It is a very thin facial expansion, and it has a unique feature in which it has no osseous attachments. So it attaches to the meniscofemoral portion of the joint capsule, the medial gastroc tendon, and the adductor magnus tendon expansion. So it does not attach directly to the bone. A structure that is very important for us as surgeons is the MPFL. It forms a distinct layer superficial to the medial joint line, and it runs in close association with the vastus medialis oblique muscle towards its insertion on the patella. It is easiest to identify at this insertion point. It is important to understand that it occupies around 40% of the proximo-medial aspect of the patella, and it runs posteriorly and attaches at a junction between the adductor magnus and the superficial medial collateral ligament over the soft tissue areas at this junction point over here, which is important to know during its surgical reconstruction process. The adductor magnus tendon is a thick tendinous sheath that is attached over 3 mm posterior and 2.7 mm proximal to the osseous depression from the tubercle. It is not attached directly to the tubercle. That is the important differentiating feature. You can see how it is closely oriented with the medial gastrocnemius tendon insertion and the by way of its thick facial expansion. It also has close association with the posterior oblique ligaments, especially the capsular arm and the posterior medial capsule. The medial gastroc tendon is found in close proximity to the gastrocnemius tubercle, exactly 2.6 mm proximal and 3 mm posterior to a depression that is found adjacent to the gastroc tubercle. With respect to the adductor tubercle, it is found 5 mm distal and 8 mm posterior. Like the adductor magnus tubercle, the medial gastroc is also found in close association with the surrounding soft tissue, especially with the posterior oblique ligament, which attaches here, and the adductor magnus that is attaching here. So the attachment point of the medial gastroc is exactly between these two, that is shown adjacent to the gastroc tubercle. Next are the pes anserinus structures. These attach in a linear fashion coming from posterior medial and attaches over the anterior medial aspect of the proximal tibia in the order of sartorius, gracilis, and semitendinosus. The sartorius being the superficial of the three, and gracilis and semitendinosus found deeper to the superficial fascia. The footprint is exactly 8 mm for sartorius, 8.2 mm for the gracilis, and 11.3 mm for the semitendinosus. There's commonly a bursa also that is found deeper to the pes anserinus but superficial to the superficial MCL ligament. The semimembranosus tibial attachment, it divides itself at the point of attachment into the capsular, the anterior tibial arm, inferior popliteal arm, distal attachment for the inferior arm, and the direct arm, of which the anterior and direct arms are the most important. The anterior arm of which is found deeper to the superficial MCL attachment, and the direct arm proceeds to the proximal aspect of the proximal posteromedial tibia, posterior to the medial tibial crest and distal to the posteromedial joint line. Now, to recollect all the structures that we've gone through, first we started off with the osseous structures, the landmarks, of which 3 are the most important: medial epicondyle, the adductor tubercle, and the gastroc tubercle. We learned about the 2 MCL ligaments, the deep and the superficial. The posterior oblique ligament, which has 3 components: the capsular, central, and the superficial. The MPFL, from its attachment to the medial aspect of the proximal aspect of patella to the junction between the adductor magnus and the semimembranosus. The adductor magnus tendon, pes anserinus, the medial gastroc, and the semimembranosus. These are the important structures of the medial aspect of the knee. Thank you.
Thank you, Ashik. Bony anatomy and deep tissue anatomy wise, you told in detail, but it would have been nice if you would added some neurovascular uh, surface anatomy also, because when we approach the medial side, we should be aware of the surfiness, where exactly it comes. So information on that would have been useful. And biomechanics is covered in the next talk, right?
So this was posted as anatomy of
Anatomy.
the only.
Okay. Anatomy wise, you told in detail what's required in the medial side. Neurovascular anatomy and a little bit of developmental anatomy also would have been little useful. Otherwise, whatever is important for diagnosis and surgical intervention, where all your structures which you mentioned is very important when you do an MPFL reconstruction or a MCL augmentation or reconstruction. All of these structures are very important. You must also understand how closely the MPFL femoral attachment comes in with the MCL. So that's why most of the time when a proximal MCL tear is there, MPFL also avulses as a sleeve. So when you repair it, both can be repaired at one shot, where you put a suture anchor there and just pull everything together and put it back. So that anatomy is also very important. Nothing much to add. Thank you. So any points from you?
No, it's okay. Done well. And I don't know, with this articles of Laprade didn't contain all this venous and all that.
No, sir. It contained only the osseous and the soft tissues only. I went through the results and the discussion both for both these articles, sir.
Okay. Right. I think probably the topic should be surgical anatomy rather than just anatomy. Right. Thank you. Well done.
Thank you.
Good morning, sir. Is my screen visible, sir?
Yes, Chetan, but some echo feedback is there. Go on.
Yes, sir. So today I'll be talking about posteromedial structures of the knee, mainly about the clinical and radiological. Posterior lateral corner, which was actually referred to as the dark side of the knee by some authors due to the lack of knowledge of its complex anatomy. We found out that even less is written about the PMC, yet being the important, being as important as posterior corner in medial ligament injuries of the knee. And the posterior medial corner is overlooked both as an injury and also on MR images. So the definition states that the PMC, the posterior medial corner, lies between the posterior margin of the longitudinal fibers of superficial medial border of the posterior cruciate ligament. So it is between the longitudinal fibers of superficial MCL and to the medial border of PCL. So there were two concepts of describing the posterior medial corner. Warren and Marshall stated that it consists of three layers. Layer 1 being the deeper crural fascia, 2 being superficial MCL, and 3 is made up of joint capsule and deep medial collateral ligament. So this is the pictorial representation. This is the superficial or crural fascia. This is layer 1. Axial section, this is the layer 1. And the layer 2 is superficial MCL. Crural fascia is layer 1. Layer 3 is joint capsule along with the deep MCL. The components of deep MCL being meniscofemoral and meniscotibial ligaments. So this is according to Warren and Marshall concept of 3 layers. Later, Robinson et al. Divided medial aspect of the knee from the medial edge of patellar tendon to the medial edge of gastrocnemius into thirds. And the superficial MCL being the middle third, anterior to it is the anterior third, and posterior to it is the posterior third. So the above 2 diagrams represent the 3-layered anatomy of medial corner according to Warren and Marshall, and below is according to Robinson. So posteromedial corner comprises of 5 important components: the semimembranosus tendon and its expansion. So semimembranous tendon is the most important dynamic stabilizer of the knee, and we can actually say the posteromedial corner can also be represented as semimembranosus corner. The second one being the oblique popliteal ligament, the posterior oblique ligament, POL. The fourth one being the posteromedial joint capsule, and the last one being posterior horn of the medial meniscus. So to the semimembranous tendon, as I already told, it is also referred as semimembranosus corner. Coming to its important structures, this is the semimembranosus tendon, a direct arm getting attached deep to the POL. So this is the superficial MCL. Just posterior to this is the posterior oblique ligament. So the direct arm or the principal attachment of the semimembranous tendon passes deep to the POL and gets attached onto the posterior surface of the tibia. And the capsular arm. So capsular arm gives attachment to the capsule, and also also joins with the capsular portion of the posterior oblique ligament. So capsular arm of semimembranosus attaches to the oblique popliteal ligament, which will be explained in the further slides. And it also gives extension to the OPL as an anterior arm which passes deep to the POL and gets attached to the middle aspect of the tibia. And it has an inferior arm which gets attached to the inferior surface of the posterior aspect of tibia. So direct arm inserts just below the joint line on the tubercle cord called tuberculum tendinus. This is the tuberculum tendinus, this area. And the capsular arm blends with the posteromedial capsule. Posterior oblique ligament. The extension of OPL, blends with OPL as the name suggests. Anterior arm inserts to the medial proximal tibia, passing under the POL. Images. So this is the picture A, which shows white arrow shows this is the superficial MCL, and just posterior to it is POL. So this is the section, axial section, femoral condyle. This is just the joint line. So as we come posterior, the ligament is well identified. And you can also see the main tendon of semimembranosus vessel, This is sartorius, gracilis, and semitendinosus. So this is the lower section where the tendinous portion gets gives its expansion. This is the expansion to oblique popliteal ligament. And in the third picture, we can see the superficial MCL, and this is the semitendinosus muscle. And this is the expansion to the oblique popliteal ligament. So this is the inferior arm going. This is the axial sections on the tibial plateau to the tibial shaft. So we can see the inferior arm expansion going and getting attached on its insertion. So in the figure 4, this black arrow represents the principal attachment of the semitendinosus muscle. So this is principal attachment of semitendinosus muscle. This white arrow is the inferior arm getting attached to the lower part of the tibia. Coming to the posterior oblique ligament, it is also called ligament of Winslow. As we already saw, these are the 3 layered structures which we discussed. So this forms the part of layer 2 along with superficial MCL. And as we already saw in that picture, the POL blends with the anterior margin of the superficial MCL. So the POL blends with the anterior margin of superficial MCL. And posteriorly it blends with capsular 3 and is capsular layer 3 and is insert. So we can see this is the superficial MCL along posteriorly will be the posterior oblique ligament, and it is attached to the joint from this point onwards. So initially, posterior oblique ligament was found to be having its origin in adductor tubercle, but Lapred et al. In their anatomical study found that the origin is actually distal and posterior to it. This is adductor tubercle. As we already saw, superficial MCL will be just anterior to the POL. Coming to the components of posterior oblique ligament, it has 3 important arms: the central or the tibial arm, the central or the tibial arm, and most important, it's attached to the medial aspect of the medial meniscus and the adjacent tibial surface. So this is the central arm. The distal or superficial arm blends with the posterior margin of SMCL, as already said, and passes superficially to the main tendon of the semimembranosus. So this picture also depicts 3 arms. This is the capsular arm, which is in continuous with the capsular arm of the semimembranosus, as we have already discussed. So capsular arm of POL and capsular arm of semimembranosus forms oblique popliteal ligament. So seeing the same anatomy in MR images. So picture 8 depicts this is a superficial MCL. So this is the anterior cut. This is the cut at the femoral condyle level. So we are just posterior to it, and the posterior oblique ligament becomes evident. So the curved arrow from B to D represents posterior oblique ligament. This is superficial MCL. So we can see the anterior arm or the tibial arm of the semimembranous tendon getting attached to the posterior horn of medial meniscus. And this is the inferior arm of the semimembranous tendon. So there are slight hazy wavy fibers along the midline. This is oblique popliteal ligament. So summarizing the parts of semimembranous tendon on MR images. So we can actually see this is the main semimembranous tendon. This is the anterior tibial arm. This is the inferior arm of the semimembranous tendon. So this is the posterior oblique ligament in close relation to the medial meniscus. So it is just posterior. And this structure, this small blackish structure is the oblique ligament. Coming to oblique popliteal ligament, it arises from capsular arm of posterior oblique ligament, lateral expansion of semimembranous tendon. So laterally, the opal attaches to osseous or cartilaginous fibula, the meniscofemoral portion of the flexural lateral joint capsule, and hence it plays a very important role both posteromedial corner and posterolateral corner. So this is the image depicting the semimembranous tendon, the oblique popliteal ligament. So oblique popliteal in the null section. Actually, see the oblique popliteal ligament from the main joint per se. So the fourth and fifth structure being the posteromedial joint capsule and the posterior horn of the medial meniscus. It forms the part of layer 3 along with deep MCL with its meniscotibial and meniscofemoral. So it is reinforced externally by POL, which is actually a component of layer 3, forming posteromedial joint capsule. So this is the layer 3 with its deep MCL with its components. Along with its basic structure is meniscotibial of deep MCL. Biomechanics and function of the posteromedial corner. Semimembranosus is the main dynamic stabilizer of the PMC, as we already discussed. So during the membranosus is parallel to the femur, and hence it restraint to the valgus motion. As the knee is flexed, there is unlocking of the knee where the semimembranosus flexes the tibia and also internally rotates it. So in flexion, it is into the external rotation. So in flexion, the semimembranous tendon flexes the tibia onto the femur and just internally rotates it. So on flexion, it is external. It is the constraint for external rotator, and in extension, it is constraint for the valgus restraint. So, and this protective effect on the medial meniscus and also the external rotation constraint is maximal at 90 degrees of flexion and decreases as the knee moves away from 90 degrees of flexion. So the protective effect of the medial meniscus is actually described as brake stop mechanism, which I will explain in the further slides. So adding to it, the semimembranosus also causes tension of oblique popliteal ligament and posterior joint capsule, stabilizing them. And hence, we noted that oblique popliteal ligament plays a role in both PMC and PLC, and thus works synergistically with the popliteal stability of the PLC. Also, it works synergistically with the biceps femoris on the other side for dynamic stability in internal and external rotation of the knee. So the posterior oblique ligament provides restraint against valgus stress, anterior and posterior tibial translation, and is important stabilizer against internal rotation against all the knee flexion angles. So the most important point to be remembered here is it is the important stabilizer against internal rotation at all knee flexion angles, whereas semimembranosus was stabilizer against external rotation. OPL being the posterior structure, is the primary restraint to knee hyperextension and is important to prevent genu recurvatum. This is the break stop function of the medial meniscus, which is aided by membranous tendon, where constant traction on the posterior posterior horn of the medial meniscus through its attachment to the posterior horn of the medial meniscus causes damage to the posterior horn of the medial meniscus at extreme degrees of motion. So this function is really important of the posterior horn of medial meniscus to stop anterior translation of the tibia. So let's imagine this break stop function is lost, and thus the meniscus and femoral condyle move as a unit sliding over the tibial articular surface. So this is seen as shown in the picture. So the meniscus along with the femoral condyle moves posteriorly sliding over the tibial articular surface, causing increased stress to other structures and increased risk of injury to the tibial articular surface, meniscus, and other ligamentous structures of the knee. So the correlation and the synergistic effect of MCL and PMC. Superficial MCL is the primary restraint to valgus stress in all angles of flexion. Deep MCL is secondary static stabilizer providing restraint to valgus stress. PMC is an additional stabilizer providing 1/3 of the restraint to valgus stress when knee is in extension. So PMC takes 1/3 of the load of the SMCL. This is confirmed confirmed the cases where there is isolated MCL injury. Posterior oblique ligament acts as important stabilizer, secondary stabilizer for the rotation and valgus stress. So this is the study where they described the anatomy in detail of the posterior medial corner. So posterior medial corner is an important secondary stabilizer of the pure anterior tibial translation. This is an additional effect, and hence in high athletic individuals in where ACL is insufficient, they will be able to perform their activities, with their athletic activities, because PMC will be taking care of it. PMC will be taking care of it. So this is the additional point to be remembered. PMC being secondary stabilizer to anterior tibial translation. So coming to the POL, it is secondary stabilizer to posterior tibial translation, particularly in extension. So this will discuss in the clinical aspects in the further slides. So the point to be remembered is POL is posterior tibial stabilizer of posterior tibial translation in extension. PMC injuries. PMC, as we saw, is a dynamic system, and any cascade of the entire posterior medial capsule. Without the dynamic support from the semimembranosus, the stresses are transferred to the remaining components of PMC, leading to their failure over time and ultimately leading to instability. So this paper by Leprad et al. In the mechanism of injuries and the related to it and its reconstruction. So the most important feature is anteromedial rotational instability, posteromedial corner. The mechanism of injury in posteromedial corner is, we can here, it's the valgus stress applied to an externally rotated tibia in the flexed knee. So we can see it is valgus and externally rotated, causing stretching of the medial side of the knee, and ACL being the secondary restraint to the valgus can also give away and gets torn. So anteromedial rotational instability is defined as external rotation with anterior subluxation of the medial tibial plateau relative to the distal femur. So, and once this happens, the medial structures are given away, the ACL is given away, and the rotation, this anteromedial rotated instability acts on the PCL with its central axis during this translation. Simultaneous MCL and PMC injuries create potential for this anteromedial rotational instability. So coming to the anteromedial pattern of the injury, so we already saw there's strain on the medial aspects and also tear. So we can see the complete tear of MCL and this complete tear of ACL in axial. There is no ACL here. Found in the third pictures where ACL is torn. MCL is also torn. And in the picture 2, there is also strain on the deep MCL and the meniscofemoral component. And this is the osteochondral fracture. And we can see bony contusions on both femoral and tibial surfaces. So this is the study by Tedros et al. In June 2018. They studied about the medial supporting the structures of the knee with emphasis on the middle. Just as we saw the mechanism of injury in anteromedial rotational instability. So what happens is, this is another mechanism of injury where there is straight valgus instability. Hence, the center of the knee is shifted from the actual center to the lateral femoral condyles. And this green point represents the shifting of the center to the lateral aspect of the knee joint. So owing to this mechanism, structures located to the middle side are subjected to abnormal tensile force. The key restraints being the superficial MCL and the middle supporting structures and ACL, both of which are subjected to tensile forces. But the medial supporting structures being far away from this point enjoy the large moment arm, and they are most effective and primary restraints of the valgus force, whereas ACL is just next to this point of contact. So this has the shorter moment arm and serves as secondary restraint. So the main restraint is by the medial structures and ACL being the secondary restraint. Now, identifying the straight valgus instability. So we can see the tear of deep MCL here, this whitish structure, and there is absence of ACL in the sagittal section. In the arthroscopy view, there is ACL. Also, hyperemic changes involving posteromedial capsular ligament. So just when this is the important point to be carried is when we as we see the arthroscopic images, we it is just seen as ACL tear along with some hyperemic changes in the medial capsule, but clinical examination and MRI imaging before the surgery actually plays a very important role owing to the most serious injuries, which is actually hidden through this actual picture in arthroscopy. So in PMC injuries, 9%, semimembranosus in 70%, peripheral meniscal detachment in this injury of all three was seen in 90%. UL is the most commonly injured structure. So this is the plain X-ray showing the avulsion fracture of the insertion of semimembranosus tendon, the tibial plateau. So the same is seen on the MRI image on the axial. Once this causes, as we saw in the previous slides, that break stop mechanism, the semimembranous tendon attachment to the posterior horn of medial meniscus. So it causes tear in the posterior horn of the medial meniscus due to avulsion. So how to say whether it is a partial tear or strains or complete tears. So the article by gave the salient features where partial tears or strains have internal intensity in the tendon. Whereas complete tears are seen as disruption of tendon with retraction and hematoma filling the gap. So I will explain in MRI images. So first image. So this is the torn, the torn and retracted semimembranous tendon, which is actually not seen. It is retracted above. This is cut at the femoral condyle. So semimembranous tendon is just above this cut, and the entire gap of semimembranous tendon is filled up by the semitendinosus. Medial head of gastrocnemius is seen. We can see the superficial MCL and the POL are torn and retracted proximally. So this is the black structure is the superficial MCL, which is away from its attachment, and this is the attachment of the POL, which is retracted. So here the medial retinaculum is also torn, and some bony contusion seen on the lateral condyle. So when we saw that direct valgus loading, that image which we saw, so due to loading on the lateral aspect of the knee joint, so there are contusions seen on the lateral condyle. So we'll be it is quite natural for us to keep concentrating on the medial aspect of the knee, but due to valgus loading, we'll see contusion on the lateral aspect of femoral and tibial condyles. So this is the B and C images are the mid and posterior, mid-coronal and posterior coronal sections. So we can see the complete tear in the MCL and the POL. So this is the anterior, relatively anterior section. This is the posterior section. So anterior section shows SMCL, the relative anatomy which we discussed in the beginning, and this is the little posterior section. So this is POL and this is superficial MCL. So we differentiate between superficial MCL and POL based on the relative cuts. So this is an anterior cut and this is the posterior cut. And also we see the meniscocapsular separations, and as I told, direct loading at valgus stress causing bony contusion on the lateral condyles. So this is the these last two images are intercondyle region in the intercondyle region, and this is the middle femoral condyle. So we can see there is complete tear of PCL and tear of oblique popliteal ligament and meniscocapsular separation. So coming to that, the differences of sprain and the tear. So sprain actually appears like this. The entire tendon appears little thickened, hypointense, and sometimes because of edema, it also has hyperintense features. So this is sprain. Into this where sprain affecting the posterior oblique ligament area, and the joint capsule, and this is the proton density fat saturation showing the meniscocapsular separation here, and also joint effusion. So this is the image where there is tear of the this image in the image B shows tears of the superficial MCL and proximal POL. This is the case of PCL. So again, tear is reconfirmed. Superficial MCL is torn, and meniscofemoral ligament is also torn. This is part of deep MCL. So this is the POL. So here we see superficial MCL, and this is POL. And also contusion on the lateral femoral condyle. So this image shows complete ACL tear and meniscocapsular separation. So we saw the area of oblique popliteal ligament and the previous images. So this absence of that structure shows tear in the oblique popliteal ligament. PCL sprain, we can see the. So this is concept where the direct attachment of the ligament to the bone, if it is at right angles to the bone, it is more stronger, and tear at this junction causes contusion in the bony attachment. So whereas if the attachment is oblique, seen in the distal attachment of the MCL. So here there is no contusion. The MCL where the fibers are perpendicular to the bony surface, causing contusion. So other special condition, Stener-like lesion, where the superficial MCL is actually beneath the pes anserinus. So it gets torn and gets interposed superficial to the pes anserinus. So we can see there is tear in the superficial MCL, and this structure, the short arrow, is the pes anserinus, and the superficial MCL is actually getting entrapped superficial to the pes anserinus. This is Stener lesion of MCL. So a note about Pellegrini-Stida disease. It is the chronic injury of MCL leading to intra or periligamentous ossification. So we can see in the X-ray and also confirmed on the MRI images. So this is the cut at the shaft of the femur, and we know this is just proximal to the superficial MCL attachment. So it represents chronic MCL injury. So as we were talking about direct valgus impaction, where the load, the center of the knee is actually shifted to the lateral aspect of the knee. So the TCL or the MCL equivalent injuries is seen in pediatric patients. Also sometimes, so there is physeal element here, and entrapment of nearby periosteum or the medial supporting structures into the physis. So clinical manifestation of posteromedial corner injuries, 72% of injuries was sports, particularly football. Other injuries being rotator. Important test performed for PMC injuries, which is performed at extension. This is the study by Singh et al., where they described the diagnosis and management of the posteromedial corner. So valgus stress is done at 30-degree flexion. So if there is medial opening at 30 degrees of flexion, it is just superficial MCL. So if it is opening at extension, it is deep MCL component and oblique ligament injury. So the point to be noted is if it is opening at extension, it should raise the suspicion for concomitant ACL injury. And grading is according to American. So grade 1 injuries is from 0 to 5, 2 being 6 to 10, and 3 being more than 10. So this is to confirm the anteromedial rotational instability. So it is anterior drawer test is actually performed with the foot in neutral rotation and external rotation. So increased anterior tibial translation in external rotation is indicative of AMRI. So the posterior drawer test. So anterior drawer test is done in external rotation. Posterior drawer test is done in internal rotation. Increased tibial translation with the tibia internal rotated suggests combined injury of PCL and the PMC. So we learned that POL also has restraint against posterior tibial translation. So interpretation of dial test. So dial test is done in prone with 30 degree and 90 degrees of flexion. So in both 30 and 90, everything is normal. If it is positive only at 30, it is posterior lateral corner injury. So confusion arises when it is positive at 30 degree and 90 degree. So it is indicative of both posterolateral corner and PCL injuries. And also the most important point is it is an indicative of medial PMC corner injury. So the dial test positive in 30 and 90 degree is indicative of both medial structures of the PMC and PLC. Hence, this pathological external rotation is not pathognomonic for posteromedial corner injuries. In to dissect it further, in posteromedial corner injuries, the anteromedial aspect of the tibia subluxates anteriorly on the femur, and in posterolateral corner injuries, the posterolateral aspect of the tibia subluxates posteriorly on the femur. This is the X-ray imaging. So valgus stress radiographs are made with the knee 20 degree of flexion. So a more than 3.2 mm side-to-side difference in the medial opening is actually consistent with complete superficial injury. And if this opening, the difference of opening is more than 9.8 mm, it is indicative of entire PMC injury. 3.2 is MCL and 9.8 is PMC. So learning the MR images till now. So anyone can actually volunteer to spot out the diagnosis in this image. So let me make it a little clear.
Yeah, Arun.
So there is a sprain in the MCL. This is, and there is
Chetan, wait.
medial
Let others answer.
ACL is gone.
Chetan.
Meniscotepsular separation here. ACL gone. MCL is gone. Striated. Take home message. Failure to address a PMC injury during surgical management of other injuries can lead to increased stress on reconstructed knee ligaments, eventually leading to their failure. So PMC has 5 major components, the semimembranous being the most important. The semimembranous is the main dynamic stabilizer of PMC. PMC is a dynamic system, and injury to any structure is capable of disabling the functional cascade of the entire posteromedial capsule. Hallmark of PMC injuries is AMRI, anteromedial rotational instability. Thank you, sir.
Thank you, Chetan. Am I audible? Chetan?
Yes, sir.
Yeah, yeah.
Okay. Chetan, you covered a lot, but you should be time conscious. You did cover a lot, but you should have spoken a little more faster to cover the same subject. It took 45 minutes, but it did convey the message clearly. So, Chetan, what did you learn new while preparing for this talk? What has your thinking changed? So, when you read about all this, or you had already some knowledge of what is the posteromedial corner?
No, sir.
So, our conventional thinking would be to think of it's a valgus stabilizer. So, but you did mention it stabilizes in varus, it stabilizes external rotation, it stabilizes internal rotation, it stabilizes anterior translation. So, I mean, how could you defend that? How could it stabilize every aspect of the knee?
Sir, it is basically towards its the expansion of the PMC, sir. Like it has expansion to the oblique popliteal ligament, having control over the posterolateral corner. It has the extension to posterior horn of medial meniscus, and the semimembranous goes anterior all the way in the medial aspect of the knee and gets attached in the medial side. Oblique popliteal ligament being the posterior stabilizer. So posterior oblique ligament also, sir. So
Yeah, that's one aspect, and other aspect is a static as well as a dynamic. Where static is prevent opening, dynamic it's like a pull and push kind of a thing, where it acts as a secondary stabilizer for so many other aspects. But two main things which we should be careful and we should remember in our day-to-day practices. Mainly, it's a valgus stabilizer in extension, posteromedial corner, and a secondary stabilizer for anterior translation, or even a pivot shift. For our regular ACL patients, they might come up with grade 3 pivot even in the presence of one posteromedial corner injury. As you had shown that door stopper effect, or we call that stop door effect. So that is a very, very important concept as the meniscus, posterior hornopedial meniscus, which is a part of the posteromedial corner, prevents the anterior translation of the tibia as well as the rotation of the tibia, internal rotation. So that's the pivot shift grading increases if that is torn. So if there is a posterior hornopedial meniscus capsular meniscal injury, there would be increased grade of pivot. So repairing that becomes mandatory, like in a ramp lesion. The concept of ramp, repair, everything comes with stabilizing this door stopper effect. Apart from that, you did cover so many other aspects. Semi-membranosus, you said 5 slips are attached, right?
yes, sir.
Okay. Semi-membranous was my first year anatomy question. I think 7 slips are there in as per Chaurasya. So semi-membranous is the anatomy also so varied, various literature says. So various slips, some say 3, some say 5, some say 7 slips are there. As you mentioned, because of the very directions of the semi-membranosus, the actions also vary. And semi-membranous is a dynamic structure. So if such structures are torn, restoring the dynamic aspects are not possible with static reconstruction. So that also we must be aware of. And this anatomy, this paper is the landmark paper which actually gave the anatomy of the posteromedial corner and highlighted its importance. Most of the medial structure uh, papers where they talked about reconstruction, they used to tell POL must be fixed in flexion. Then after Laprad's biomechanical study, then they said deep MCL and POL are supposed to be stabilized in extension. Then the whole concept changed, and stabilization and extension is very important because that's the functional motion for us. So if it opens up in extension, then your gait will be altered. Tight opening and flexion, stair climbing is affected, but that superficial MCL tends to heal. But this POL and deep MCL do not tend to heal as good as the superficial. That's also another important concept. Nothing much to add after that. Sir, your point.
Very well covered and a lot of details, and you also gave a good summary. Is it possible for AMRI to occur independently?
Sir, MRI, for MRI to happen, there should be tear in MCL and also posteromedial corner.
What about ACL piece? Yeah, correct.
It can happen. Locum description is that, but I cannot explain isolated mechanism where this alone tears. Probably a mechanism which tears both and other aspects have healed fully or partially, and as a result, only the posteromedial corner where it's not healed will result in AMRI. We have seen such cases where they complain of that rotational instability alone. Sir. Probably
Yeah.
MCL would have healed, and only this aspect were not healed. But functionally, they're not too bad unless they're an athlete.
But athletes keep coming with issues for a long time.
Unless athlete. Other thing is this hyperextension. Sometimes a few patients who come and the posterior capsule is torn and little hyperextension on this side. For an athlete, that will be troublesome. Tightening that again, it's a challenge.
Chetan, it's good that you stopped and asked question. You'll have to wait for the answer. Only then, the fellows will be able to participate. Good. Thank you. Well, Mas, when you put up the program, you must put what plastic talk it is. You have to ask them. You have to ask them what's the plastic talk next week, and not just put plastic talk as if you're not involved in it. In future, please do that.
Okay, sir. Sorry, sir. Okay.
Good morning, sir. Is my screen visible, sir?
Yeah, yes, sir.
Yes, sir. So today's topic is on preoperative planning in total knee arthroplasty. The uses of preoperative planning is that through the thorough preoperative planning is critical in optimizing the implant position and soft tissue balancing, and it also helps the surgeon to visualize the procedure, anticipating the potential complications to ensure the availability of required instrumentation and selection of appropriate implants, and also to counsel the patient about the complications. The significance is that the preoperative planning has been shown to prolong the implant survival and reduce the duration of the surgery, and it also prevents the unnecessary additional steps during surgery. The history must include age and sex, BMI of the patient, characteristics of the knee pain, level of activity, functional limitations, involvement of other joints, and previous treatment history such as intra-articular steroids. The presence of comorbid conditions, smoking status, alcohol consumption, medication, and mental status should also be assessed. And male patients in particular are high risk for BPH, and hence the UTI during and post-surgery catheterization should be taken care of. And if needed, they should be for the history collection must include their frequency of micturition and any other symptoms such as burning micturition. And if needed, we have to obtain a neurologist consultation and ultrasound abdomen. So this is a study. It states that the perioperative medical management of symptomatic benign prostatic hyperplasia is an economically justified prosthetic joint infection prevention strategy. Dementia, diabetes. This study has shown that the dementia, diabetes mellitus, body mass index above 40, and renal cerebrovascular disease have been shown to be independent predictors for in-hospital mortality and post-operative complications after primary TKA. Hence, all these histories are important. And an assessment of the patient's overall venous thromboembolism risk, including any history of previous deep vein thrombosis or pulmonary embolism, should be obtained. And patients with neuromuscular conditions such as Parkinson's disease are at high risk of instability following TKA, and they may benefit from specific implant options, that is varus valgus constrained TKA or hinged knee component designs. Moving to physical examination, should start with patient's gait. We have to observe the overall knee alignment and presence of thrust or hyperextension during walking, which indicates a ligamentous laxity, indicating a need for constrained design. And hindfoot inspection, as the hindfoot valgus, it tends to shift the medial, it tends to shift the mechanical axis of the lower extremity after TKA. And the previous surgical scar should be examined. And this article states that when there is multiple previous incisions are present, the most lateral incision should be used, and that at least 5 to 6 centimeter of skin bridging be provided between the incisions to avoid post-operative skin complications. Then the assessment of fixed coronal or sagittal deformities for planning intraoperative correction strategies must be assessed, and then examining the pre-op range of movement. This article supports that the preoperative range of movement remains the most important predictor factor for post-operative motion. And a thorough neurovascular examination should be performed to rule out peripheral neuropathies and vascular pathologies. And suspicion of vascular compromise always warrants a vascular surgery consultation. Another article, it states that the patient with pre-existing peripheral vascular disease are at high risk of arterial injuries and compromised blood flow during TKA, and the surgeon should consider not using the tourniquet during the procedure or inflating it just at the time of cementing. Finally, the assessment of ipsilateral hip and ankle joint and the contralateral limb should be performed to evaluate the involvement of these joints and the effects they may have on the patient's post-operative mobility and rehabilitation. Blood investigations must include complete blood profile, inflammatory markers, sugar levels, and HbA1c, LFTs, and RFT. And this article on HbA1c for planning TKA, it has proposed that achieving a HbA1c level of less than 8% is acceptable to avoid substantial delays in performing a TKA. And regarding hemoglobin, this article concludes that the risk of transfusion is increased 3.7-fold for each 1 gram decrease in Hb level below the threshold of 13 grams preoperatively. Then moving to radiographic examination. The standard radiographic evaluation for patients undergoing TKA includes a full-length radiograph from hip to ankle, a weight-bearing AP view of the knee, lateral view of the knee, and a patellofemoral skyline view. In a full-length radiograph, it allows the surgeon to rule out extra-articular deformities, estimate the amount of coronal laxity, plan the bone resection, the position of femoral and tibial components with respect to mechanical axis, and to calculate the overall deformity. It is typically taken with both knees in maximum extension and patient's knees placing 18 inches apart. And the rotational position of the lower extremity may influence the reliability of the measurements. Hence, it's important to have the patella facing forward. The first step is to measure the hip knee ankle axis, and then marking the overall mechanical alignment of the lower extremity. The varus or valgus malalignment and any other extra articular deformities should be noted. Then valgus cut angle. When an intramedullary distal femoral cutting jig is required, the valgus cut angle or the femoral resection angle, it is the difference between the mechanical axis and anatomical axis of the femur. And this angle most commonly measures between 5 and 7 degrees of valgus. And article by Mulaji et al. Showed that this VCA angle can vary from 3 to 11 degrees of valgus, and author suggests using individualized femoral resection angle rather than a fixed resection angle based on the case. Then lateral distal femoral angle and medial proximal tibial angle are supplementary measurements for assessment of lower limb alignment and to assess the severity of bone loss due to arthritis and the coronal orientation of bone cuts in relation to mechanical axis. The AP weight-bearing view is typically obtained with the X-ray beam focused on the knee joint and the patella facing anteriorly. It is scrutinized to detect medial or lateral osteophytes and bone defects. The true lateral view should have no overlap between medial and lateral femoral condyles. It is typically used to detect the posterior osteophytes, to measure the tibial slope, the patellar height, and the patellar tendon length. Next, the patella skyline view. The tangential axial view of the patellofemoral joint is performed with the knee in 30° of flexion, and it is used to measure the patellar tilt shift at the congruence with the trochlear notch and to evaluate the extent of erosion of the patellofemoral joint. This article by Shiruchia et al. Showed that the preoperative lateral patellar shift of 3 mm or more is an independent risk factor for patellar maltracking during TKA. Next, the spine radiographs can also be obtained to rule out knee spine syndrome and its potential complications. In addition to these, for unicondylar knee, additional radiographs are required, which are the preoperative stress X-rays. The X-rays are taken with patient in supine with knee in 20° flexion, which is to relax the medial lateral stabilizers. And then the X-ray beam is angled 10 degrees cranially to ensure that the X-ray beams are parallel to the tibial joint surface. The valgus stress view is obtained for a medial UKA. This is done to verify the integrity of the lateral joint space, laxity of the medial soft tissues, and anticipate the final alignment post implantation. If the medial joint space opening is inadequate, or if there is a reduction in lateral joint space during this valgus stress view, TK is preferred. And in each view, the osteophytes are identified for removal, which would further aid in the deformity correction. Then the next step is to look for special situations like bone loss. This will help to anticipate additional inventories like augments, cones, extenders, and stems. And also certain extreme bone loss scenarios will demand specific designs like a hinge knee. Then we have to look for extra-articular deformity. The distance of site of deformity determines how much it contributes to deviation at the joint. And for example, a 10-degree varus deformity in tibia, which is at the junction of proximal 1/4 and the distal 3/4 of tibia, will contribute to 7.5-degree varus. That is 3/4 of it at the knee joint. Thus, the influence of extra-articular deformity is inversely proportional to the distance from the knee joint. That is, the farther it is, the less influential it becomes. And based on this calculation, deformity can be corrected. The correction can be done either at the level of cora or near the articular surface. Next, moving to templating. This is the final step, and transparent templates are available for superimposition over the radiographs. To get this done, to get the alignment and measure the component sizes. We have to add a calibrated reference marker such as a ball or coin at the level of joint line. It increases the accuracy of the sizing and tibial of the tibial and femoral components during templating. And using this technique, this can predict the component size within one size larger or smaller, almost always for the tibia, and during 90% of the time for femur. Steps of templating. Starting with the femur, we should choose the appropriate implant size on the lateral radiograph, and then restore the posterior condylar offset and anteriorly avoid notching. Then assess the size of the component on AP radiograph and also to determine the medial lateral positioning and ensure there is no overhang. If there is a significant overhang, we have to consider downsizing. And in tibia, choose the appropriate size implant on the lateral radiograph and ensure there is no overhang and aim to match the native tibial slope. And assess this component size on the AP radiograph to determine the medial lateral component positioning and again ensuring there is no overhang. Then consider downsizing if there is any overhang. So this is the final picture after pre-op templating of both tibia and femoral components in AP and lateral radiographs. Rarely a CT scan is indicated, but the advantages of CT over X-ray are that the ability to measure angles and distance in 3 dimensions, and it's of greater accuracy. And the problems associated with plain X-ray, such as perspective distortion, magnification errors, and orientation uncertainties, are overcome with this. Studies have also shown that a preoperative CT or MRI knee is obtained only when the patient-specific instrumentation or custom-made implants are used. So this is an overall algorithm for selection of implants. When the primary TK is planned, it starts with history and physical examination, and then radiographic templating is done. If it's a straightforward TK, the surgeon may opt for a cruciate retaining or a posterior stabilized implant. And if there is a complex TK, such as when there is a severe coronal or coronal deformity, when there is a severe valgus, if MCL is intact, consider a posterior stabilized TK, and CR is also acceptable in some cases. And if the integrity of MCL is lost and the patient is elderly, consider a varus valgus constrained TK with or without MCL reconstruction. And if it's not an elderly patient, consider a posterior stabilized knee with MCL reconstruction with a backup of valgus varus constrained TK. And if there is a severe varus deformity, consider a posterior stabilized or cruciate retaining TK with stepwise soft tissue releases and a backup of varus valgus constrained TK. And if there is a extra-articular deformity and intra-articular correction is achievable, consider using extramedullary guide or a short intramedullary guide, and consider using a computer-assisted navigation. And if the intra-articular correction is not achievable, consider for a corrective osteotomy. If there is a bone defect less than 5 mm, it can be filled with cement. And if it's more, consider using metal augments. So the pre-op checklist, there must be a thorough history and physical examination with radiographs with angles measured and templating done. Cardiac and vascular consultations if necessitated. And by this, we should anticipate the deformity correction method, the appropriate implants, that is the size of the implant, positioning, posterior stabilized or cruciate retaining implants, and any special material of implants such as oxynium. And in addition to that, other inventories such as stem or augments. The take-home message is that the preoperative planning is a culmination of thorough history and physical examination, a careful evaluation of adequately obtained radiographs, and a meticulous templating. The success in executing the preoperative plan leads to a sense of accomplishment on the part of surgeon, reproducible results, minimal complication, better operative efficiency with less operating time, and most importantly, a satisfied patient. Thank you, sir.
Thank you, Sumar. And from your observation, what are things we have to improvise in our preoperative planning? So you must have observed over the period of time, and you have reviewed the various articles. So anything which we are lagging in that part or to improvise in our pre-op checklist?
Nothing in specific, sir. Almost all of this we are doing, sir. Some patients, they present late with very high HbA1c, sir. And articles are in support of HbA1c less than 8.
Basically, why I opted this topic is because we have this NIBH auditing also. So
Yes.
based on the guidelines, we can cross-check with our performer and checklist whether we are following the standard guidelines and to improve, and anything which we are lagging in the evaluation or we have to improvise it. Number one. Number two, what about this nutritional status?
And in few papers and few centers, they're concentrated on albumin levels. The nutritional status of the patient is very important in optimizing the patient preparing for TPR.
Yes, sir.
Dr. Yuvarajan, I
Yes,
have
sir.
two questions.
Yes,
Do
sir.
you institute a nasal swab and also a dental clearance? It's
Sir, we
pretty
don't.
standard here
Yes, sir.
to get a clearance from the dentist or make sure that there are no dental problems, cavities, caries, and also a nasal swab.
Yes, sir. But the recent consensus by a pervasive group, sir, in the 2018, what they found that the overall consensus shows that there is no strong recommendation for nasal swab because it doesn't affect outcome. So we are not using any nasal swab, sir. Previously, we used to do that nasal swab, but the consensus shows that there is no difference in taking a swab or without a swab. Number one. Number two, for the dental caries, for the specifically we ask in a history. So those patients they have a caries or they high risk for any dentures. In those specifically, we used to get an opinion for a dentist, sir.
Okay,
Yes, not for all the
thank you.
patients. Thank you, sir.
Good morning, sir. Arun here. While practicing in our own setup, when can we actually ask the patient to do a spine X-ray to rule out knee spine syndrome?
Especially when they come with overlapping symptom with backache with a radiculopathy pain, Arun.
Yes.
And especially when they have a severe virus with significant waddling gait with lateral thrust in the knee. So in those patients, it's better to screen the spine. The recently also we had one patient with significant knee pain, but in that patient, the X-ray shows a significant L5S1 listhesis, but it has auto stabilized. So in those patients, we can prognosticate in the post-op if they present in later stage with radiculopathy pain. So we can hint the patient that the patient is also having the spine issue in addition to the knee. So easy for them to counsel or prognosticate the patient.
Okay. And another question, yesterday I saw a patient who had been operated for L5S1, it's the same as you said, but the patient have been having the symptom only for 1 year and mild radiculopathy only. There is not much of neurological symptoms, but he has been having this grade 4 ONE for the past 7-8 years. So if at all, if that patient comes to us, what should we operate first and how we should approach the patient?
So basically, we look into the severity and patient symptoms as well as the clinical examination. So that's what the pre-op clinical examination is the key. So leave about the X-rays and MRI, and majority of the patients do come with a LS spine X-ray and MRI because outside they evaluated for the back pain. But when you evaluate the patient, they have a significant pain in the knee, they have a difficulty in walking. And if they're neurologically okay, those patients you can operate up for a primarily knee. But in those situations, you have to evaluate clinically the neurovascular examination is very important and tell them that post surgery you might require an intervention for the spine. It depends on the clinical examination only we can decide whether you can go for a knee first or spine first.
Okay.
You have to decide, yeah, clinical.
You presented a paper on this also, isn't it? And won the medal?
Yeah, yes, sir. Knee
Ah.
spine syndrome. Sir.
Yeah.
Yes,
Arun, glad you're asking questions. You can ask the fellows, past fellows, and read that
Yes,
paper
sir.
there.
Yes, sir.
yes, sir. Yes. Arun, I think it will become mandatory in future.
Yes, sir.
The patients with grade 4 OA with presenting to us with a severe waddling gait, I think you should screen the spine because now it has become mandatory for the all hip procedures. because we have to look for the motion as well as inclination. We call it as hip spine syndrome, as well as it'll change the component orientation also. Similar to that, the knee spine syndrome is the which is already is proven one, but we are not documenting clinically. But we brought up these issues recently. That's what is got appreciated in our presentation also, because we have to prognosticate the patient and we have to document clinically, and it will give a good outcome when you are operating, especially with patient with a grade 4 or grade 3 lysis with neurological involvement. So it will change the entire clinical outcome. Yeah, that is very important.
Okay.
Okay.
Thank you.
But Yuvraj, that spine X-ray, we are not doing it as a routine. No, we do it only if indicated.
But nowadays, the anesthetists are asking mandatorily.
Okay, like a chest X-ray, spine X-ray.
Yes, chest X-ray. Yes, yes.
So it's easier to document, and okay, screening also is easy. Okay.
Yes, screening as well as for the spinal aspects also, they are feeling that it's better to get a screening X-ray of LS spine. Few cases they found it's very difficult, and post-op they found all completely ankylosed spines. Yeah.
Most of our patients whom we refer for arthroplasty, they must be already having the spine X-ray because some pain here and there. It's a good idea to get it get the spine X-ray also done compulsorily.
Yes, sir.
Gopal, we are trying to post. We've been debating over it. I think we better decide on it to post 15 days the arthroplasty fellows with Scopy. And I think the vice versa also. The Scopy guys also should be posted 15 days in arthroplasty. But that's so that they have the proper exposure. And,
I totally agree.
Don't feel so detached with
Yes.
the plasty.
And, I agree with that because I'm trained all around. I've been to every specialty, so and I practice a bit of everything. I think it's excellent.
Thank you. Thanks for participating.
Just not branded a plastic talk.
Yeah,
doesn't
that's right.
make any sense.
Yeah. So that's what we've been doing all along. I feel detached, I think.
Yes. I don't think the fellows should feel detached or aloof.
We shall implement that quickly, sir.
Yeah.
Existing process.
And especially, I'm sure Dr. Yuvarajan will back me up. In those patients we did the unicompartmental, we used to scope them first to make sure that the cartilage is not absent on the contralateral side before putting a uni in. And that was standard practice for me to put the scope into a diagnostic scope, make sure that I'm on the right track, but already prepared to do a total with the consent from the patient that it may be revised from uni to total, depending on the initial arthroscopy.
Okay, sir.
I think it's time, isn't it?
Yes, sir. We shall.
Okay. Good night,
Have
Gopal.
a good day.
Yeah.
Thanks for participating,
Great week.
Dr. Feroz.
Yeah. All right. Bye-bye.
Bye. Thank you.